We used to think neuromyelitis optica was a type of multiple sclerosis, but we now know it's a completely separate disease. And today we're going to do a review of NMO, including the clinical features, the diagnostic criteria, the findings on MRI scans, what differentiates it from MS, and of course, some of the treatments along with the results of clinical trials. And I have some timestamps if you want to skip ahead. Let's have some fun. Now, I want to give the caveat that NMO is a very serious medical condition, and the medications I'm going to discuss do have potential risks, including weakening the immune system, so I would highly recommend you talk to your own provider for medical advice. However, I'm happy to answer questions in the comments below, as long as they're phrased in a general way, because I can't give you advice on your own personalized situation. So in general, we believe NMO is an immune-mediated disease where the immune system is effectively confused in attacking the nervous system. In particular, it tends to attack the optic nerves and the spinal cord, causing symptoms such as vision loss and numbness and weakness. However, as you'll see in the MRIs that I'll show in the future, it can also attack the brain and cause various other symptoms such as nausea, hiccups, and narcolepsy. It's a very rare disease. The prevalence is estimated to be between 1 and 4.4 per 100,000. So in other words, less than 1 out of 20,000 people have this disease. It's thought to be more common in certain ethnicities, such as people who are from Japan or other areas in Asia, but it can actually happen in any ethnicity. Like many other autoimmune diseases, it's much more common in women, and in fact 90% of people with this disease are women, compared to about 75% with multiple sclerosis. The average age of onset is a little bit higher than MS. It's about 40 compared to 30 with MS, although the range of ages is tremendous. So there are young children as young as 4 that get NMO, and I personally had a patient in their 80s get NMO. Now, about 80 to 90% of people with NMO have a relapsing course of the disease without treatment. In other words, they may have an attack, for instance, optic neuritis or inflammation of the optic nerve, and then they'll have a period of quiescence. They may recover from their optic neuritis and get their vision back, or they may have permanent symptoms after optic neuritis, but then later on, they may get another attack in the future, and it could be a similar attack, or it could cause completely different symptoms, such as numbness and weakness in the legs. There are rare cases of people who have just a single attack, and there have been very rare cases of people with almost like a progressive illness, although that's quite uncommon in NMO, which is much more common in MS. NMO is also associated with other autoimmune diseases, such as myasthenia gravis and lupus. And the one thing that's very distinctive about NMO is most people, about 75% of people with the condition, have an antibody called anti-aquaporin 4, and that's seen in 75% of people using the most accurate assay called the cell-based assay. And there are many laboratories that do this test, including Athena and Mayo Clinic Laboratory. The symptoms people get from NMO have to do with the location of the autoimmune attack. So what I'm showing in this diagram is the integrity of the blood-brain barrier. So this is the neuron and the myelin sheath, and you have these supportive cells called astrocytes. And these astrocytes have podocytes, or foot processes, that form the blood-brain barrier, the normal barrier that protects the blood from the brain. And this barrier has the water channel aquaporin 4, which is the target of the autoimmune attack in most cases of neuromyelitis optica. Now, I'm not going to talk about this too much, but there are actually other antibodies that have been associated with NMO, including anti-MOG, myelin oligodendrocyte glycoprotein, and actually people with that antibody have slightly different clinical features. They're more likely to have recurrent optic neuritis, and they're more likely to get spontaneous recovery and have a better prognosis. There are also rare cases of NMO that have been associated with anti-neurofascin antibodies, but for now we'll stick with anti-aquaporin 4. So you can see in NMO in this diagram, for whatever reason, and we don't know the underlying cause, the B lymphocytes are making abnormal antibodies that target aquaporin 4. So these are the anti-aquaporin 4 antibodies, and it's a form of immunoglobulin G. And this causes disruption of the astrocyte foot processes, disrupting the blood-brain barrier, causing other immune cells to come into the central nervous system and attack, causing damage and the symptoms that we see in NMO. So aquaporin 4 is primarily in areas of the central nervous system that are touching the cerebrospinal fluid in an area known as the periependymal space. And in this diagram, we're looking at sagittal slices through the brain and brainstem like this, and you can see there's abundant aquaporin 4 in the central canal of the spinal cord, which is why you can get inflammation of the spine. And you you have this abundantly also in the optic nerves, which is why you can get optic neuritis. But as you can see in this diagram, it's also in areas around the fourth ventricle near in the medulla, which is why you can get inflammation of the area postrema causing nausea, and in the pons, so that's why you can get hiccups and double vision, and in areas around the third ventricle, which is why you can get lesions in the diencephalon. This leads to different stereotypic attacks in NMO depending on the location of the inflammation. So some of the most common would be optic neuritis or inflammation of the optic nerve, and I do have a separate video on this if you want to take a look in the card above. And the typical symptoms would be pain and vision loss. And with NMO, optic neuritis can often occur in both eyes spontaneously, whereas in MS it usually affects one eye at a time. Also, optic neuritis in NMO tends to be more severe with a lower chance of recovering vision. Also, NMO can attack the spine and cause transverse myelitis, and the lesions tend to be very long and extensive, and this is known as LETM, or longitudinally extensive transverse myelitis, and it tends to affect more of the center of the spinal cord, where in an MS it's more towards the back or edge of the spinal cord. Also, NMO can affect the area postrema, which is the back of the medulla, and can cause severe nausea and vomiting. And I've actually seen a few patients with NMO where that was their only symptom, and they often get misdiagnosed with a gastrointestinal disorder, and it can affect other parts of the medulla and cause hiccups or other brainstem findings such as incoordination and double vision, and sometimes it can affect the thalamus on both sides and cause sleepiness or even narcolepsy or memory changes, and sometimes it can cause big, large, fluffy tumor-like lesions and even be mistaken for other neurological diseases such as PRES or posterior reversible encephalopathy syndrome. So just to show some examples, this is longitudinally extensive transverse myelitis. You're looking at an MRI of the spine, and we're looking at sagittal slices like this. So these are the bones, and these are the discs in between. And the spinal cord should look dark like this, but this long white area is transverse myelitis. And typically in NMO, it can extend more than 3 vertebral segments, which is very rare in MS, although sometimes we see shorter lesions. And sometimes it can extend up into the medulla or the area postrema and cause nausea. This is known as a cervicomedullary lesion, classic for neuromyelitis optica. This is an example of optic neuritis. You're looking at an MRI of the orbits. We're looking at coronal sections like this. So this is the brain, and these are the optic nerves, and these are the muscles that control the eyes, and these are the nasal sinuses. And you can see the left optic nerve is normal, but the right optic nerve avidly takes up the gadolinium contrast dye, so this is right optic neuritis. This is an axial image looking at the optic nerves, so this is the right eye and the left eye, and you can see the optic nerves look kind of normal, but there's flattening of the disc in the back, and this is known as papillitis on both sides. Sometimes the optic nerve lesions can be further back all the way in the optic chiasm, and here you can see a very impressive example of an enhancing lesion in the optic chiasm. And this is an example of lesions around the third ventricle or the diencephalon and thalamus. And this is a patient who developed severe sleepiness but actually got better with the steroid solumedrol. And this is an example of lesions in the corpus callosum, which are common in multiple sclerosis, but often in NMO you can see this so-called dot-dash sign where you see little balls connected by linear abnormalities. It looks very strange and unusual, not typical of the white picket fence appearance that's often seen in multiple sclerosis. And finally, you can sometimes get this enhancement or abnormal inflammation around the lateral ventricles known as periependymal enhancement. This almost looks like an infection that you can get from certain neurosurgical procedures such as ventriculitis, but this patient actually had NMO. And not shown here, some people can get these large fluffy lesions that almost looks like tumors that are caused by NMO. So I have to give credit to Dr. Dean Wingerchuk, who does a ton of research on NMO and did a lot of the early research and came up with the diagnostic criteria. So he describes 6 core characteristics of NMO: optic neuritis or inflammation of the optic nerve, transverse myelitis, inflammation of the spine, area postrema syndrome, a lesion in the medulla causing nausea, vomiting, a diencephalic syndrome or inflammation of the thalamus causing sleepiness or narcolepsy, cerebral syndrome, big fluffy lesions in the brain, or another brainstem lesion causing double vision and other symptoms such as incoordination. And he defined two types of diagnostic criteria. One for people who have the antibody, anti-aquaporin 4, and another for people who don't. The idea is that although the antibody is not 100% sensitive, only 75% of people with this disorder have anti-aquaporin 4, it's very specific. So if you have symptoms and the antibody, there's a good chance that you have NMO. So for the antibody positive diagnostic criteria, you just had to have the antibody plus one of the core characteristics mentioned on the prior slide, assuming there was no other better explanation for the symptoms. However, if you don't have the antibody, it's a little bit stricter in terms of making the diagnosis to avoid misdiagnosing. So you had to have at least two of the core characteristics on the prior slide and meet the following requirements. One of the core symptoms had to be either optic neuritis, transverse myelitis, or an area postrema syndrome, in other words, a medullary lesion causing nausea. And the core characteristics had to be disseminated in space. In other words, you couldn't have one lesion causing multiple symptoms. Also, the MRI findings had to not look like multiple sclerosis or another autoimmune disease of the nervous system. Now, this all refers to people who have anti-aquaporin 4 or not anti-aquaporin 4. There are no formal diagnostic criteria for people who have anti-MOG or anti-neurofasciin. Now, I'm going to talk a little bit about the prognosis in NMO, but please keep in mind that this data is from older studies and many of the patients were untreated or treated, and we think we can do much better with modern science and modern medications. So please don't be too scared by this, but I just want to make the point that NMO is quite a serious disease. For one thing, the average number of attacks, or the annualized relapse rate, is about 1.14. So on average, untreated, people have fairly frequent attacks more than once a year, and I've seen patients with 5 or more attacks in a year. Also, people can become disabled quite quickly with this condition. So the median time to EDSS-6, which is the level of disability at which a cane is required to walk 100 meters, is only 12 years. It's much longer in historical MS studies, about 27 years untreated based on, for instance, the Queen Square data. Now, EDSS is Expanded Disability Status Scale, which is a measure of disability in multiple sclerosis and NMO research, and if you want to learn more about it, I have a separate video on that topic. Also, the median time to severe visual impairment in one eye is only 11 years. Now again, this is based on historical studies, and we now know that a delay in immunotherapy or medication to prevent NMO relapses actually is associated with a greater chance of being disabled and a greater chance of visual loss and EDSS-6. Now, the sort of good news here is that NMO, unlike multiple sclerosis, is mostly a relapsing disease. Basically, if we can stop the attacks, people tend to do well. In MS, some people, as they get older, they may not have attacks, but they may have a slow and insidious progression. That tends not to happen in NMO, and in one case series, secondary progression, in other words, progression after a history of relapsing disease, was seen in 0 out of 106 patients. So it's actually quite rare, and I have to say this is consistent with my experience. I don't really see progression in NMO. And this is just a visual of some of the data looking at EDSS-6, or the level of disability where a cane is required, and severe visual impairment in one eye, and you're looking at survival curves, and you can see after around 120 months or 10 years, about half of the people have experienced this. So untreated, it's quite a severe disease, and many doctors currently believe that we should treat NMO at the time of diagnosis and essentially for their entire life, because doctors such as Dr. Wingerchuk and others have reported that even if NMO is treated and people are stable and they come off of treatment many years later, they may actually have an attack, in some cases a severe and disabling attack. Now, because NMO is rare, it's very frequently misdiagnosed, and it's often misdiagnosed as multiple sclerosis just because MS is much more common. So MS occurs in about 1 in 350 Americans compared to probably less than 1 in 20,000 Americans having NMO, and these are just a few features that can help you distinguish between the two. So in NMO, it's much more likely to get optic neuritis of both eyes, whereas in MS, it usually occurs in one eye at a time. Also, the spinal cord lesions in NMO are often extensive and long, and you can get what's known as longitudinally extensive transverse myelitis, like in the picture I showed before. Also, in MS, usually the contrast enhancement goes away after about 1 month, but sometimes you can get very prolonged contrast enhancement in NMO, particularly if it's not treated properly. Now, we know that a lot of people with NMO do have brain lesions, up to 60% according to one case series. However, they're not usually typical of MS brain lesions, such as Dawson's fingers or the white picket fence sign or juxtacortical lesions. An experienced radiologist and neurologist should be able to tell the difference. Also, the spinal tap findings can be different. Usually in MS you get lymphocytes in the spinal fluid, but in NMO you can get neutrophils or sometimes even eosinophils, which are very rare in MS. About 90% of people with MS can have oligoclonal bands in the spinal fluid that are unique to the cerebrospinal fluid and not in the blood, and these are antibodies that attack central nervous system antigens. This can happen in NMO, but it's less common, perhaps only about 30%. Also, in MS, the spinal tap abnormalities are usually present forever, whether an attack is happening or not. However, in NMO, you could have abnormalities in the spinal fluid, such as oligoclonal bands, but they may disappear between attacks. Also, in MS, usually you see elevated immunoglobulin G synthesis, but this is usually normal in NMO. And in NMO, you can see a unique finding where you have elevated interleukin-6 in the cerebrospinal fluid. And this is a protein involved in cell signaling, and this actually comes into play in one of the treatments of NMO, as we'll see in a little bit. Now, for treatment of NMO, there are really two different things. One is the treatment of the acute attack or flare, and the other is long-term prevention of attacks. So we'll start with treatment of the acute attacks, such as optic neuritis or transverse myelitis. So the most common treatment is steroids, for instance, intravenous methylprednisolone or solumedrol, and a typical dose in adults is 1,000 milligrams daily for 3 to 5 days, sometimes followed by a lower dose of prednisone or a taper. However, in some cases, NMO attacks don't get better with steroids, and there's an alternative treatment of plasmapheresis or plasma exchange, which is a dialysis-like procedure that removes complement and antibodies. And I have a separate video about plasmapheresis if you want to take a look. Another treatment for NMO attacks is intravenous immunoglobulin or IVIG. These are artificial immunoglobulins that disturb the immune system, and they can be used both for attacks but also sometimes for long-term prevention in NMO. And a typical dose for an attack is 2 grams per kilogram, although it's usually divided into 5 doses of 0.4 grams per kilogram. Next, we'll move to drugs that don't help in the midst of an attack, but are for long-term prevention of future attacks. And unfortunately, many doctors recommend long-term immunosuppression just because attacks in NMO can be so serious. Now, as you'll see, there are actually 3 FDA-approved treatments for NMO, as I'll show next. But these are sort of the old-school treatments of NMO, but actually rituximab is probably still the most popular treatment for this disease and may be considered the standard of care. And I actually have a separate video on rituximab if you want to take a look in more detail. But it's an antibody that attacks B cells, which are the cells that make immunoglobulins, including the anti-aquaporin 4 immunoglobulin, as well as possible abnormal antibodies such as anti-MOG and anti-neurofascin or other undetectable antibodies. And rituximab is typically given every 6 months, and sometimes 2 doses are given every 6 months and sometimes a single dose. And the most common side effects are infusion reactions such as rash and hives and itching or wheezing. And it also weakens the immune system and can increase the risk of infections, which is actually true of all of these medications, unfortunately. There are also pills for NMO, such as azathioprine or Imuran, and mycophenolate mofetil or Cellcept, and these are typically given twice a day, and they can sometimes cause liver problems and gastrointestinal upset, and you do have to do blood tests to monitor for liver function and the white blood cell count. Prednisone, the steroid used to treat asthma, and poison ivy, the very old medication, is actually used on a chronic basis to prevent NMO attacks in some cases. Doctors don't like to do this because prednisone can cause weight gain, it makes you hungry, it can elevate your blood sugars, can elevate your blood pressure, but it is quite effective, and many doctors use this as a bridge while another drug becomes effective, because prednisone becomes effective very quickly. Now, we don't really have randomized trials proving the efficacy of these drugs, but we do have observational studies where we look at the rate of relapses before the drug was started and then after treatment. So this is an observational study published by Dr. Wingerchek a long time ago, and you can see that rituximab seems to be the most effective. With optimal dosing, the rate of relapses decreased by about 94%. Second placed was mycophenolate mofetil or Cellcept, and azathioprine was the least effective. Now, NMO used to be a so-called orphan disease in that it didn't actually have an FDA-approved drug to treat it, but there are actually now 3 FDA-approved drugs to treat NML, all approved relatively recently, and they are Soliris, Uplizna, and Enspryng. Now, Uplizna, or inebilizumab, is very similar to rituximab. So CD19 and CD20 are proteins on the surface of B cells that are targeted by these drugs. So Uplizna targets CD19, and rituximab targets CD20, but more or less they're trying to achieve the same thing, which is to deplete the B lymphocytes so that they can't produce antibodies. It's not known if one of these drugs is safer or more effective than the other. Certainly we have much more experience with rituximab. Another drug used for NMO is Soliris, or eculizumab, and this is a drug that was originally FDA approved to treat another rare condition called paroxysmal nocturnal hemoglobinuria, an antibody-mediated disease that causes destruction of red blood cells. And this drug works on complement. So complement are proteins that are sort of at the end of the inflammatory cascade that cause tissue injury. So the anti-aquaporin 4 antibody comes in, and then it brings in complement to do damage, and so complement are sort of targeted by this drug, so it really prevents the end of the tissue destruction. Now, there is evidence that Soliris is very effective, but some doctors are hesitant to prescribe it as a first-line treatment just because it does have the potential to cause bacterial meningitis as a side effect in rare cases. The other drug that's used to treat NMO is Enspryng, or satralizumab, and this is a drug that targets IL-6, or interleukin-6. Remember, I told you earlier that we can find interleukin-6 in the spinal fluid. Now, this is very similar to the already previously FDA-approved drug Actemra, which actually already had evidence in neuromyelitis optica, and that class of drugs is used to treat juvenile rheumatoid arthritis. And the side effect of this drug is that it can cause infections and in some cases high cholesterol, so cholesterol needs to be monitored. Now I'm going to show you the randomized trials for these 3 drugs, and these are actually randomized trials against a placebo, a much more robust form of data compared to the observational studies I showed you before. Now that we have proven drugs for NMO, a potentially serious disabling condition, I would consider randomized trials against a placebo to be unethical, and I would not recommend my patients to enter such a trial at this point. However, it did generate very good information for us. So the first drug we'll look at is Uplizna, or inebilizumab. Again, this is the anti-CD19 agent that depletes B cells and is similar to rituximab. And what we're looking at in all of these charts is the survival curve of attacks. So you start off with 100% of the people not having attacks, and it goes down and down as more and more people have attacks. So in the placebo group, about 40% of people had an attack, leaving only 60% who were free of attacks, compared to 87% on the drug. And so this was a hazard ratio of 0.27, so it decreased attacks by about 73%. Next, we move to satralizumab, or Enspryng, versus placebo, and they actually divided the patients into 2 groups. Those who had the antibodies, anti-aquaporin 4 antibodies, the so-called seropositive patients, and on the next slide, those that didn't. So amongst those that had the antibodies, the drug was effective, and you can see the hazard ratio is 0.21, so it decreased attacks by 79%. However, if they look at the people who did not have the antibody, there was actually no statistically significant difference. So it's possible that this drug is really only effective in neuromyelitis optica if the anti-aquaporin 4 antibody is present. And by the way, none of this data reflects what would happen if we gave these drugs to people with anti-MOG antibodies or anti-neurofascin antibodies. Now, the last drug, Soliris, or eculizumab, again, this is the anti-complement drug. seems to be the most effective, and it decreased attacks by 94%, a hazard ratio of 0.06, and almost none of the people receiving the drug had any attacks whatsoever. So this may be the most effective drug for NMO, but again, it has the potential risk of meningitis and is very frequently dosed, so it's quite inconvenient. So I will include some references. If you want to take a look at those studies in more detail, you can take a look, and if you have any questions or requests for future videos, please post in the comments below.